It is a great pleasure to introduce Dr. Sohel Patwardhan. He is director at Nandadeep Eye Hospital and Research Center, Sangli, Maharashtra. He is in charge of FECO training and fellowship program at Nandadeep Eye Hospital. He is a pioneer in live surgery streaming ophthalmic surgeries and on YouTube and Facebook. He is an invited faculty in various national and international conferences and dynamic surgeon. Dr. Sohel Patwardhan, please.
Yeah, thank you. Thank you so much for that kind introduction. So I'll be sharing a few of my surgical videos. And the first one which is coming up is surgery done on, in fact, one of the ophthalmologist's mother. And can you see the screen here?
Yes, yes.
Okay,
Yeah.
so I will start the video.
For education and training of eye surgeon.
It has audio already, so I will not speak during, and afterwards we can discuss.
Viewer discretion is advised, not recommended for children. Hello friends, I am Dr. Sohel Patwardhan from Nandadeep Eye Hospital and FECO Training Center. In this video, I will be dealing with a case of extremely eccentric pupil with cataract. So this was the presentation. Patient is a 60-year-old female, anesthetist by profession. She had a history of childhood trauma, and since then her vision is subnormal, around 20/60, and now there is further deterioration of the vision because of formation of cataract. And as you can see here, the pupil is strikingly eccentric as it is dragged into the previous injured sclera. So there are a few issues to deal with here. The first of all, biometry was not possible in undilated pupil as the optical center was covered with iris, so we did dilated biometry and it showed astigmatism in the cornea, so we needed toric to correct the astigmatism. And of course the most striking thing here was the extremely eccentric pupil. So let's start thinking. I'll be using iris hooks to do phacoemulsification with toric, and of course I have to do pupilloplasty. Now how will I bring the pupil to the center? One option is to cut the pupil on one side with scissors or use vitrectomy probe or something which can spare the sphincters, because either with vitrectomy probe or by scissors the sphincters are going to be damaged and we may be having a dilated pupil in the postoperative period. So the first part was to mark the cornea for the toric placement, and then I'll be using 2 iris hooks to retract the iris, and then after retracting the iris the pupil is dilated enough for doing phacoemulsification. Phacoemulsification was done using stop and chop method. I am taking extra precautions here to spare the posterior capsule because I don't want to complicate things further, and I am implanting toric IOL and trying to place it on the axis as far as possible before removing the OVD from the bag. But I will be injecting 1.8% sodium hyaluronate in the anterior chamber at the end so that I can do the pupilloplasty procedure. First I tried to release this iris from the incarcerated site. It was not possible, and you can see this is the center, optical center of the eye, which is covered by the iris even in partially dilated state. So the next step is to make this pupil more central. So I'm going to use a unipolar diathermy with linear energy, and the heat produced here is going to cause shrinkage of the collagen of these radial fibers, and it is going to retract this iris from the center. So you can watch here how I am carefully using unipolar diathermy, which we commonly use for retinal surgeries. I have seen this technique being used by Dr. Sergio Canabrava, and now you can see the optical center is uncovered, the iris is dragged on one side, and I have marked the optical center now with that blue dot, and you can see that I am further using the diathermy to shrink the iris away from the center till I feel it is adequate enough. Once the diathermy is done, after that I'll be doing single pass 4-through pupilloplasty here using 90 Prolene and using the standard railroading technique and the loop is taken out using 25 gauge forceps, and then I pass 4 throws of the cut end of the suture through this loop, followed by pulling the 2 ends of the thread using McPherson to reduce the iris defect on one side. I'll be adding one more suture in the periphery to cover the gap, and now I am going to remove the OVD from the anterior chamber, and now I am trying to check the position of the toric IL, just dragging the iris on one side and checking the final position of the IOL. I am well satisfied at the end with the outcome, and this is immediately post-operative next day. You can see the pupil is well centered, and this is after 1 month, and pupil is very well centered. Pupil is of adequate size, not unnecessarily dilated. There is no iris atrophy or pigment dispersion. The great thing is patient achieved uncorrected visual acuity of 20/20. From the point where we started and what we achieved in this particular case was really good and very satisfying.
So that was the first case. I think we can discuss about it and then we can move on to the second case.
It was really amazing, Saurabh.
Yeah, thank you, sir.
It was really amazing.
So it was an interesting case because the patients, both her daughters are ophthalmologists, in fact, cornea specialists, and they sent her images to me and asked me that this is the cataract she has and she had trauma in childhood. So how would you go about? So we discussed the technique. Actually, I said that this is what I am going to plan because this is the, the final outcome that I would like to have. Though even with eccentric pupil, maybe she will have fine vision, but if it is centered, as we know, as a refractive surgeon, if the pupil is centered, the quality of vision is always better. So that was my plan. And luckily, and this particular technique where unipolar cautery is used, I used it for the first time. I had seen maybe a couple of years back, Dr. Sergio using that technique in one of his videos. And I think it was a great technique because I don't have to snip the pupillary sphincters unnecessarily. And the pupil was reactive even in the post-operative period, which is great. Dr. Sohel, I can see Dr. Sohel had joined. So
I have one question, sir.
Yes, sir.
Hello. I got a different email and I went to some other room. So there was
Okay.
sorry for that problem. So Dr. Pampatwar, Deepak.
Yeah.
Can you hear me? Deepak Pampatwar?
Yes.
Okay. I don't know what has been done. Saurabh have to present his presentation in some other hall. So
He has finished one case.
Yeah, I have finished one. I think I will just stick to second one because I think we have more speakers after me. So I will just finish my second. Any questions or anything? Yeah, Dr. Aarti. Yes.
Hello, sir. Very good evening. And it was a beautifully executed case, I must say. Just, I think our viewers also would like to just know this, that how much time does it take for the shrinkage of the collagen after the unipolar diathermy?
Like it happens on table only, as you can see you can see the dragging of the pupil as you use. And one concern I had in mind that whether it will lead to kind of chapping or whitish spots or atrophy. Now it's almost I think 7-8 months post-op, and I think 3 or 4 months back she had a visit, but iris looks nice. So I think the chaffing is not much even in this technique. That was a little bit concerning. So I had even contacted Sergio. He also didn't have much of information, but I said that that's, I think, best way to go about this particular case.
Excellent. I was just about to come to that one about iris chaffing. Excellent. Very good, sir. Thanks.
Thank you. So should I share my second video? Is that okay?
Sure.
Yeah. Okay.
Yes, sir.
One moment. Okay.
In this video, we'll be dealing with a case of congenital aniridia. Congenital aniridia is not merely absence of iris tissue. Because of the absence of iris, the patient gets lots of glares. But apart from that, there is aniridia associated keratopathy as well as glaucoma. There is dry eyes and agal abnormalities which are associated. Limbal stem cell deficiency can lead to pannus and scarring, and foveal hypoplasia can lead to poor vision. They are also associated with systemic syndromes like WAGR and Gillespie syndrome, and cataract is a common presentation to have. While dealing with cataract in the case of congenital aniridia, we can use aniridia IOL or we can use aniridia rings and segment to reduce the glare post-operatively. There are custom-made artificial iris as well, but they are expensive. So I am presenting a case of congenital aniridia with intumescent cataract, a 18-year-old girl one-eyed with sudden diminution of vision. We expect low scleral rigidity, irregular cornea because of the scarring. Patient has nystagmus and already on anti-glaucoma medication. Young guy with lower scleral rigidity and intumescent cataract elastic capsule is a difficult case to handle. You can also see some kind of fibrosis in the anterior capsule here. I use the sodium hyaluronate and chondroitin sulfate combination, a heavier viscoelastic agent, and that is going to help me during CCC. I tried to aspirate out the fluid from the intumescent lens, but it was a dry tap, and here I should have started doing the capsulorhexis rather than trying to aspirate. Now I am injecting little bit of more viscoelastic here, but avoiding overfill of the chamber because as you can see the tears are already going out. So I decided to make another tear with the cystitome and try to enlarge the rhexis around this tear which was trying to go out. So I was able to manage it from one side and I could pull back the rhexis. So now it was time for the other side. Use of heavy viscoelastic agent is definitely useful, and using microcapsulorhexis forceps to guide this capsulorhexis helped me in getting a complete capsulorhexis, though it was a bit larger in size and oval in shape. It was a very soft cataract as expected, so just phacoaspiration was required to remove the nuclear material. Capsular polishing and cortex aspiration was done, and now I decided to implant the aniridia rings. Now the problem that we may expect during implantation here because of the large rhexis is that there is a chance that it might come out of the bag while I am rotating it in the bag. I have enlarged the incision little bit so that the flaps on the ring are not caught and broken. It is important to guide each flap into the incision and into the anterior chamber very carefully to avoid any damage to the ring. And the last part is directed using a forceps into the bag. And as I expected, the superior part of the ring was out of the bag. So I decided to do this by manual maneuver where I retracted the ring with the Sinski and then held it using the forceps and then guided it into the bag. Before doing that, I inflated the bag well with hyaluronate. So using proper OVD during the course of the surgery is very essential for the success of the surgery. Now the second ring is being implanted, and to avoid that ring going out of the bag, what I did is that I inserted this ring under the first ring, that is posterior to the first ring, and for this part also I carefully inserted it under the first ring, and then the IOL is placed in the bag. Also again, I saw to it that the haptics are behind these rings so that there will be capsular fibrosis and fixation of the IOL in the bag. So this is how the patient looked at the end of the surgery, and patient got good 6/60 vision. There was foveal hypoplasia. Patient was extremely happy with the visual outcome. Thank you.
Okay,
so
that was an excellent video, Saurabh.
Yeah. Okay. Any questions on this? Okay.
Saurabh, can I ask you something?
Sure, sir. Sure.
The IOL goes in front of those rings or anywhere behind the ring, or doesn't it matter?
Because in this case, the capsular axis which I wanted, it was like bigger than what I would have, planned. So in this case, what I did is that I placed the IOL haptics behind this CTR so that they don't come out. If it was of a normal size, like say 5 mm rexis was achieved, then I think it wouldn't matter because the anterior capsule will hold it down. But here, I think I use those flanges actually to hold the IOL down.
So you place the IOL behind those rings?
Behind those rings, yes, sir.
Okay. Nice video. Amazing.
Thank you, sir. Thank you so much.
Sir, is my screen visible?
Saurabh?
Yes, Deepak.
Yeah, insertion of the iris segments, is it going to be difficult if the rexis was smaller? In this case, inadvertently, it was bigger.
Yeah.
Is it going to be smaller or easier?
No,
is it going to be difficult or easier if the rexis is 5 mm?
It will be easy because, yeah.
Okay, because the first, it just came out, the first segment came out. That could be avoided, I guess.
Yes. And that's what, during the procedure, actually the plan changed. I mean, in between, I thought whether I should put the rings or not. But I had already planned it. So I thought that let me try whether I can get them into bag. And luckily with this maneuver, I could push them into the bag. So I could do what was planned.
And second thing, the gaps in between those two segments which you have put, will there be light transmission and will it cause any dysphotopsia, something like that?
So I think the solution is not very ideal. Maybe we want maybe a 4 mm or 5 mm size.
Yes.
So with these rings, these are 2.5 mm basically size rings. There is also 3 or 3.5, but they become much bigger and bulkier. But I think even with 6 mm, it's fine with aniridia because these patients are already used to, lot of glare. So even if we reduce that peripheral light a bit, for example, this particular patient is quite happy. I mean, earlier the glares were too high, and now she says that, it's quite acceptable. And of course, they have poor vision because of foveal hypoplasia, so they are not going to have very perfect vision.
Is my screen visible?
Yes, sir. Yes.
So please make it full screen, sir. Slideshow options. Click on slideshow.
Top left-hand side is there. Yeah, there, right, just right. You want to right side? Yeah.
From beginning, yeah.
So very warm welcome to all the speakers and panelists for this excellent, amazing video session. And after the presentation of Dr. Saurabh, because Dr. Saurabh is leaving, so I am going to introduce Dr. Saurabh's a little bit. May I request Dr. Deepak Pampatwar to introduce Dr. Saurabh?
He has already introduced, so I think we can.
Already introduced.
Yes, thank you.
Now I have the honor and privilege of introducing Dr. Deepak Megur sir, who heads the cataract and glaucoma department at the Megurai Center, Bidar, Karnataka, and specializes in complex cataract surgeries. He is very much committed in sharing and teaching surgical skills. He has, to his credit, a very vast number of videos, excellent quality videos with a very high quality recording on his YouTube channel. And also he has got a phacotraining.org additional website where you can go and watch his videos. As far as awards and recognitions are concerned, he was awarded the prestigious CS Reshmi Award for the best video in the last AIOC 2020. And he's also winner of best paper of the cataract session in AIOC 2018. Besides that, he has to his credit best free paper in cataract and video at KOSC 2019. And the list is on and on. He is now going to present an excellent video which has got a very good educational and informative content: hard cataract phacoemulsification, pristine cornea, a myth or reality. And the second video he's going to talk about is demystifying anterior vitrectomy for the cataract surgeons. We have as a panelist an excellent, renowned phacosurgeon from Ranaghat, West Bengal, India, Dr. Pradeep Mohanta, sir, who is a dynamic and prolific surgeon, and he's very sincere, and he has got a selfless and passionate, he's a passionate person with an obsession for teaching the surgical skills to all the young ophthalmologists all over the world. And his submarine phaco chop is his excellent innovation, and he's going to talk about how to tame a granite hard cataract. He did his MS from PGI Chandigarh and a VR fellowship from prestigious Shankar Nethralaya, Chennai. He is the founder and director of Netrajot Eye Hospital, Ranaghat, and has a tremendous interest to produce good ophthalmic surgeons all over the world, sharing his surgical videos in the YouTube. He is, as I told you just now, he's going to talk about submarine chop, his recipe for taming a luminescent cataract. And he's also going to talk about his transition to pre-chopping. Saurabh is over. That was an excellent presentation. And I will be the last speaker. Pampatwar.
Yeah, Dr. Sohel Irfan Khan is Associate Professor at Government Medical College, Nanded. He is a dynamic eye surgeon and great academician. He is the winner of AIOC 2020 Best Video and Best Technique Award in the Challenging Video Symposium. He is also the winner of World Webinar in Cataract and Refractive Surgery Cataract category for his innovative chopper. Dr. Sohel Irfan Khan will be speaking, giving his last videos on conquering soft cataract through pre-chop, glamorous MICS, a phaco surgeon NY, and hard cataract pre-chop.
YouTube. May I request Dr. Meghur sir to
Deepak, are you going to?
Hi.
Meghur sir's video are already on the list on the YouTube. 1 second.
Yes. I opened one. Okay, if you allow, I can share the vitrectomy one. It's ready now. Okay. In the meanwhile, you can just get the other one ready. Okay.
Yeah, please.
Yeah, I'll doing it now. So I think this will be on the anterior vitrectomy for cataract surgeons. So I'll just start.
Today I'll be talking about anterior vitrectomy.
The audio is audible, right?
Yes,
Yes,
sir.
yes.
Technique which is to be learned and mastered by every cataract surgeon, as it's inevitable for us to come across PC tear and vitreous disturbance. I have prepared this presentation in the form of question and answers, and I have titled this as the whys and hows of antivitrectomy, the answers every cataract surgeon should know. I would say that a beginner resident, even doing his or her first case, should be knowing all the answers that will make them battle ready. So let's begin. What's the goal of antivitrectomy? Is it to remove the prolapsed vitreous? No. The answer is the goal is to remove the prolapsed vitreous without causing any traction to the vitreous base. Not causing traction to the vitreous base is probably the most important goal we need to understand. Usually, out of sight is typically out of mind. It is critical for us to understand that any pull on the vitreous is going to induce vitreoretinal traction, which is not visible to us but can eventually lead to a giant retinal tear, which is extremely difficult to manage, as we all know. Hence, the principles and technique of performing antivitrectomy are targeted towards achieving this most important goal. We also have a secondary goal while performing antivitrectomy, and that goal is to prevent the enlargement of the posterior tear, provided it is still small, so that it gives us an opportunity to implant the lens into the bag. So the secondary goal is to prevent enlargement of the posterior tear during antivitrectomy. Is the technique of performing antivitrectomy very demanding skill-wise? Well, the answer is a simple no. It is just as skillful as any other step, like creating rhexis or cortex aspiration. You just hold the instrument and cuts the vitreous. Of course, some basic principles need to be understood and followed. So what is the basic principle of antivitrectomy? It is to cut first and then aspirate. By cutting first, the chances of inducing any traction to the vitreous base is minimized. So cut first and then aspirate is the fundamental principle. What's the device and how does it work? Vitrector does a dual job of cutting the vitreous and then aspirating it. The motorized probe has a guillotine-like blade which moves to and fro, which cuts the tissue, and the hollow lumen inside the probe aspirates the cut tissue. The cutter can be driven pneumatically or electrically. Pneumatic cutters are the most commonly used, and pressure from the compressed air moves the blades to and fro. As I change the speed of the cutter, the frequency of the oscillations is increased or decreased. Similarly, we have vacuum, which helps in aspirating the cut vitreous. So why do we need irrigation? To keep the eye pressurized, so that the structures are maintained in a very normal anatomical position during the procedure. As the antechamber is well formed, it minimizes any trauma to the corneal endothelium. Well, this is the basic principle of any intraocular surgery. The next relevant question would be, is a closed chamber technique mandatory? Well, the answer is yes. It's always preferable to have a closed chamber technique. Typically, we make two side port incisions, one for irrigation and the other for the cutter, with the main incisions, the bigger incision, being sealed, either with suture or they being self-sealed. It's important to have the instruments snugly fit in the incisions, as leaky wounds are to be avoided, as the vitreous has a great tendency to prolapse towards the leaky incisions. Closed chamber is critical as it helps to perform the procedure with all the structures being present in their anatomical location, which ensures better visibility, less trauma to the corneal endothelium. Rarely we may have to go through the main wound to get better access to a certain quadrant, but generally it needs to be avoided. Now moving on to the parameters, how to set them and what are they? The first and most important parameter for me is going to be the bottle height. Starting off, it has to be very low. Low infusion pressure is the key. I start off with a bottle height of as less as 30 centimeters, and let me explain why. Whenever a posterior capsule tear with vitreous prolapse has happened, we would have already used some OVD to fill the chamber. And we need to remember that typically during most steps of cataract surgery, we would have used a bottle height of 90 centimeters. And in a state where the antechamber is already filled with viscoelastic and it is reasonably pressurized, when we enter the chamber with a bottle height at 90 centimeters, the fluid suddenly gushing inside is going to bloat and enlarge the posterior capsule tear. So the most important parameter when we begin antivitrectomy is to adjust the bottle height. The tip here is to always start with a low bottle height and then gradually increase it as the vitreous and the OVD get aspirated. So we need to understand that bottle height is dynamic. We begin with a low bottle height and gradually increase it. Now moving on to the next most important parameter, it is a cut rate. We need to set the highest cut rate what our machine can afford. The reason is simple. Higher the cut rate, lesser is the chance of traversing the shock waves back towards the vitreous space. Most machines have cut rates varying from 800 to 5000. So the rule of the thumb is choose the highest cut rate which the machine can afford. Vacuum has to be low or moderate. It has to be just high enough to evacuate all the cut vitreous, but low enough to maintain the antechamber stability. Aspiration flow rate, it is used only in peristaltic machines when we are using all the vitrectors through the phaco machines, and typically I set it at 10 ml, which is the lowest possible in my machine. The bottom line is parameters should work in such a way that the vitreous can be dealt with swiftly and efficiently without compromising the chamber stability. Now moving on to the typical foot position settings. This is referring to a vitrectomy machine built into a phaco unit. So typically we have these three settings. The first position is going to be on irrigation, the second position for cutting, the third would be for aspiration. And this is what we want to follow because we want to cut before aspirating. Some machines have the option of changing the settings to irrigation first, then aspiration and the cut mode. I call this the IA cut mode. This is used only in certain situations, mind you, after the vitreous has been adequately dealt with. I predominantly use it for removing epinucleus in cortex and for performing iridectomy. Where do I hold the irrigation cannula? Well, it is to be held just adjacent to the side port incision which we have created, but nowhere near the posterior tear. It has to be as far away from it as possible. The idea is the fluid has to be directed towards the angle, not into the torn posterior capsule area. We don't want the fluid to go through the posterior tear. How do we hold the cutter and where do I position it? Ideally, the vitrector is to be held at the level of the posterior tear or slightly below it, with its port facing anteriorly to begin with, so the vitreous anterior to the tear is first cut and then pulled back posteriorly before being aspirated. There are two reasons for doing this. By pulling the vitreous back, we are less likely to enlarge the posterior tear, and by cutting the vitreous and pulling it back, we are less likely to exert any traction in the vitreous space. These are the exact same principles and reasons why the pars-plana approach to antivitrectomy is preferred in the current times. Now this is a case which has this posterior tear. Please note the size. After staining the vitreous, the prolapsed vitreous is seen. The vitrector is positioned at the level of the posterior tear and the cutting is begun. It takes a couple of minutes to clear it. Subsequently, the port is turned sideways and posteriorly to remove the surrounding vitreous. By following these principles, we can see that the size of the posterior tear did not enlarge during antivitrectomy, and the size remained the same until the end of the surgery. Another case with a small peripheral tear, the vitrector is held at the level of the posterior capsule while performing antivitrectomy, and again we can see that we could prevent the enlargement of the posterior capsule tear. Now how do we visualize the vitreous? We all know that triamcinolone acetate is a great tool to stain the antivitreous. Now how do we use the triamcinolone acetate? Typically, it is advisable to be used in a diluted form. The recommended dilutions would vary anywhere between 1:4 to 1:10. I prefer to use the 1:4 dilution method, where 1 part of triamcinolone is mixed with 4 parts of BSS in a 1 ml syringe, and we stain it. Important point to note here is that rarely some patients could be steroid responders. Although majority of the triamcinolone acetate is washed off, it still would be mandatory that all of these patients are monitored for any pressure spikes in the early post-op period. What is the end point of antivitrectomy and how do we know it? Once the prolapsed vitreous is clear from the antechamber, one can feel that the antechamber fluttering or microshallowing starts becoming obvious with the same settings which we had begun with. This happens because the jelly-like vitreous would be occupying the space, and once it is cleared, the same vacuum and the bottle-height will not be able to maintain the same antechamber depth. It's quite difficult to demonstrate clinically, but I'll try to show it here in this case. As the vitreous is cleared off, we can see these corneal folds appearing and the chamber starts to flutter a little bit. The eye appears to become very soft now. And these are the early clues indicating that the prolapsed vitreous has been cleared. Of course, using triamcinolone acetate is definitely conclusive. I usually do it a couple of times, once before implanting the lens and finally before closing it. It's important not to overdo antivitrectomy. We don't want to remove the vitreous unnecessarily. It has to be just enough to keep the pericapsular bag area clean. Now, what are the advantages of pars plana technique? Dr. David Chang and Dr. Vasavda and few others have been advocating the use of pars plana approach to perform antivitrectomy, and they have demonstrated certain major benefits, few of them being the lesser chance of the posterior capsular tear to enlarge. It's a more physiological approach to deal with the vitreous. It has got a lesser chance of inducing vitreoretinal traction. And lastly but not the least, there is lesser chance of endothelial damage. Now, how do we perform antivitrectomy through the pars plana approach? The irrigation is through the anterior root, that's a limbal paracentesis incision which we have created. For that vitrector, we need to make a small conjunctival peritomy. An incision with a sharp 23G MVR blade is made 3 mm posterior to the limbus. The incision is typically a stab incision pointing posteriorly towards the midvitreous. Mind you, it's not going to have any tunnel effect. We don't want any tunnel effect. It has to be just a stab incision directly going through and through, directing towards the midvitreous. The cutter is introduced but without any action. The foot is off the pedal now. First, I need to go and visualize the port through the pupil. The port is facing anteriorly. And then once I'm sure that where the port is there, then I begin cutting and then aspirating. It's important to realize that we have a chance of cutting the intact posterior capsule, so we need to be careful about this aspect. Since we can minimize the chance of extension of the posterior capsular tear by using the posterior approach, we have a better chance of implanting the lens into the bag in most case scenarios. Finally, the sclerostomy has to be closed with the atovitral suture followed by conjunctival closure. That's it. These were some of the answers that every cataract surgeon should know regarding antivitrectomy. Thank you.
I'm sure that was an excellent video which has got a phenomenal information for all the cataract surgeons. Why I'm not in a position to share my screen? Yeah. So I'm going to play the second video of Dr. Deepak Megur sir that deals with how you can obtain, how you can obtain clear cornea, a pristine clear cornea, day one post-operative. He's going to tell us.
So the voice is not coming.
Yeah.
I think
you need to share
stop.
with computer audio.
I think you have to just go back and say, optimize, stop sharing now.
Stop sharing.
When you click the share button, no, there is an option, checkbox will come. Optimize video and share computer sound. That you have to click when you share.
Such a rock hard nucleus, difficulty in dividing the nucleus, potential damage to the endothelium, higher chances of capsulozonular complications. Hi, we have this 80-year-old gentleman with this brown, very dense cataract. Let's understand and discuss few issues which we face while managing such. Hi, we have this 80-year-old gentleman with this brown, very dense cataract. Let's understand and discuss few issues which we face while managing such nucleus. These are the few of the expected challenges while managing such a rock-hard nucleus. Difficulty in dividing the nucleus, potential damage to the endothelium, higher chances of capsulozonular complications, and possibility of wound burns. We need to understand that apart from being a very hard and dense nucleus, it also is a bulky nucleus occupying almost the entire bag. So few precautions are to be taken. Number one would be adequately sized rhexis. This is very critical as a larger rhexis makes it easier for us to manipulate the nucleus, putting less stress on the capsule at the zonules. The rhexis here is around 5 mm, but I would have liked it to be slightly bigger, maybe 5.5 mm. Nevertheless, we need to continue and let's see how things fare. Number two would be during hydrodissection, we need to be extremely careful in using very limited amount of fluid to do hydrodissection to prevent posterior capsular blowout, as some of these cases have got very thin posterior capsule. The free nucleus rotation confirms the lack of any corticocapsular adhesions. Since this is a hard nucleus, I need to get a very good grip on the central deeper part of the nucleus for successful chopping. To get access to the deeper part of the core nucleus, I'm creating a small central pit so that I can bury my tip deep into the central core of the nucleus, which will help me in cracking the posterior plate more efficiently. Please note that my assistant is constantly pouring cold BSS over the incision site to minimize the chance of wound burns. I'm burying the tip deep into the nucleus and creating my first crack using a vertical chop technique. The crack is initiated, but I'm unable to achieve the first crack through and through. So I'm going to rebury my phaco tip once again and trying to laterally separate. I can see that the posterior plate is still not completely separated. I am unable to place my second instrument deep enough, and this is the reason which is preventing the posterior plate from cracking. So no problem, just rotate the nucleus and then I continue to chop. The chopping and lateral separation is being done at progressively deeper planes, and posterior plate is quite tough. And eventually, with sustained effort, the posterior plate gets separated, but still some part of it is attached. I continue to chop vertically the first heminucleus, and you can see that when during lateral separation, sometimes I am stretching the rhexis margin. So this is something which I need to be aware of. While trying to chop at a deeper plane, I am unable to place the second instrument because of the lack of space. However, with a little bit of persistence, I could manage to place the instrument deep enough, and during lateral separation, the first complete separation of the fragment could be finally achieved. I want to emulsify this free fragment now itself so that it creates more space within the bag. The settings are changed now. The quadrant is carefully emulsified at the pupillary plane. Now I'm injecting dispersive OVD, underneath which I'm injecting hydroxypropyl methyl cellulose. The HPMC is less thermogenic, so I always prefer to put it in the bag and around the pupil, whereas the dispersive OVD is much anterior nearer the cornea. I'm using my chopper to cut the few connections of the posterior plate of the fragment, and once it is freed, I begin emulsifying the fragment. Kindly note that the plane at which it is being emulsified, we can see that part of the fragment is brushing around the rhexis margin, confirming the posterior plane of emulsification. The chopper on top of it ensures that none of the fragments move above to hit the endothelium. Well, there is one such rare fragment which escapes out but is quickly emulsified. Okay, now the first piece is emulsified and we continue to chop the remaining heminucleus. The remaining part of the heminucleus is again chopped into smaller fragments. Again, the technique of progressive chopping and lateral separation to deeper plane is carried out. And all these fragments are then very patiently and slowly emulsified under great control. Again, it's time to replenish the OVD. First, the dispersive goes in, followed by HPMC underneath it. It is a sort of a modified soft shell technique. Now I'm performing the horizontal chop using a blunt chopper. The posterior plate separation is difficult. Instead of struggling with the lateral separation, I go ahead and phaco that part of the attached posterior plate. This is possible since the bag is relatively empty and we have access to the posterior plate, and by manipulating it anteriorly, the areas which are attached are emulsified, thus freeing up the fragments. These fragments are then consumed in a very controlled manner. Even during the last fragment removal, please note that the majority of the nuclear fragment is still in the bag behind the iris during emulsification, confirming the posterior plane of emulsification. My chopper is just above the phaco tip so as to prevent any fragment from flying around and hitting the endothelium. The only trick to have such control during emulsification of the fragments is to go slow, and this is achieved by using lesser energy. By doing so, we'll be minimizing lens chatter and turbulence. The amount of energy delivered is being controlled by the foot pedal. The only price we're paying here for such control is time. For example, this case took almost 3 times the time which I would take for a routine case. If we think from the other point of view, we can emulsify all these fragments in a fraction of few seconds, literally destroying them by just increasing the power. But the consequences would be higher amount of lens chatter and turbulence, which will result in mechanical trauma to the endothelium and postoperative corneal edema. So that's the price which you're paying. So by going slow, most of the things are under control. Okay, the final last fragment is out. And just have a quick look at the CDE, that is the cumulative dissipated energy which is used. It's very high. It's almost 10 times more than my routine soft cataract cases. So let us see how much impact does it have on the corneal endothelium in the post-op pictures. The lens is implanted and the case is done. Now is the time for the results. The next day, well, the patient is quite happy and so am I. The cornea is clear and smiling at us with minimal antechamber inflammation. So there are few learnings from this case. The first common myth that increased energy consumption is deleterious to the endothelium and causes endothelial damage, is not entirely true. Ultrasound energy alone is not responsible for endothelial damage. You can see that in spite of such a high amount of energy which was consumed during the procedure, the cornea was still crystal clear. The more important factors here would be controlled emulsification of the fragments with very little chatter and turbulence. These principles are far more critical in minimizing the mechanical trauma to the endothelium. And if there is very less lens chatter and turbulence, then we are confident and we can work at a much more posterior plane, which again minimizes the mechanical trauma to the endothelium, and also the exposure of the energy, ultrasound energy to the endothelium is little bit far away. So again, you are minimizing the amount of ultrasound energy which is exposed to the endothelium. Of course, frequent and multiple shots of OVD are extremely critical and they do protect the endothelium. Above all of them, patience is the greatest virtue to have in such cases. By following these principles, we can achieve clear corneas on post-op day 1, even in these rock-hard cataracts. Given a second chance, apart from having a slightly bigger rhexis, the other thing which I would have done differently would be to create a tip which is much more deeper than what I'd created in this case. I would go rather 90% depth so that the initial cracking maneuver would be more efficient and less stressful on the rhexis and the zonules. That's it. Hope you found this helpful and thank you for attention. This film is intended for eye surgeons for training and education purposes.
Stop sharing.
Viewer discretion
Sohel.
is strongly recommended.
Amazing videos, Deepak.
Yes,
Thank
sir.
you, sir.
I think besides his phenomenal clinical skills, surgical skills, and dexterity, it was an sheer patience also that determines very much the success of
The answers every cataract surgeon
surgical outcome.
should know. I would say that a beginner resident, even doing his or her first case, should be knowing all the answers.
So now we have Dr. Pradeep Mohanta sir, who is going to talk about his submarine chop as a technique to deal with a granite cataract, which is a brunescent nucleus.
To us, but can eventually lead to a giant retinal tear, which is extremely difficult to manage, as we all know. Hence, the principles and technique of performing anti-vitrectomy are targeted towards achieving.
Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract.
Can you hear
We
the
can
commentary,
see
sir?
the
Yes.
brownish
I'm not in a position to.
of the cataract. Let us observe this surgery. This is the main incision.
Just try to increase the volume of the laptop.
You can see oozing of some blood from the lips of the main wound.
It's
This is a
maximum.
side port on the right side of the main incision, and this is another side port on the left side of the main incision. These side ports are about 3 clock hours away from the main incision. An air bubble has been injected into the anterior chamber. Now trypan blue 0.06% dye is applied over the anterior capsule underneath this air bubble. This is a bit of adrenaline, and now the dye is thoroughly washed out using BSS and this 23G Simcoe cannula. And now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The anterior chamber is filled up with this viscoelastic substance. A 26 gauge bent needle cystotome is used. It goes through the right side port, incises the anterior capsule, and raises a large, nice to hold capsular tag. I take a Utrata forceps now, hold this capsular tag, go anti-clockwise, and do a large rhexis, not less than 6 millimeter. Yes, in hard cataracts, we should do a large rhexis so that nucleus management becomes easy. And now, hydrodissection. BSS is passed just under the anterior capsular rim, and the nucleus is tapped and the nucleus is mobilized. Viscoelastic substance is injected again, and now is the time to introduce the tip of the phaco needle. In hard cataracts, to deliver more ultrasonic energy, the exposure of the tip, the exposed part of the phaco needle should be little more. It is this much in other cases. In these cases, I rotate and expose little more so that more ultrasonic energy can be delivered into the nucleus. And in this case, I am going to do submarine chop. Submarine chop means you go through the substance of the nucleus as a submarine moves through water. You go through the endonucleus and break the hard core of this hard cataract, and you divide the nucleus at on-go. Here it is. The nucleus is pushed little down, and now the tip of this phaco needle is buried into the substance of the nucleus. I am asking my assistant to increase the power, ultrasonic energy in this case. In other cases, it is about 60 to 70%. In this case, I have asked to increase the ultrasonic energy to 85%, and there is some cavitation bubbles. I remove these air bubbles, engage the tip into the substance of the nucleus. It goes through the nucleus towards the opposite equator, crosses the central hard part, and when it reaches between the center and the other equator, the chopper is used to chop this nucleus, and it is a very nice crack. Rotate this 180 degree, and along this crack I separate this nucleus into two heminuclei. Yes, it has completely separated into two parts. And now again the tip is buried into the substance of the heminucleus, goes through it for a distance, and it is chopped into two large fragments. Done. Rotate the nucleus, come to the other heminucleus, bury the tip into this heminucleus, go through it for a distance, and then chop it into two large fragments. So this large, in other words huge nucleus has been divided into four large fragments. Now each fragment is tilted and emulsification is started from its apex. I don't allow the apex to go back and hit the posterior capsule. I start emulsifying from the apex, and it gets emulsified in a short time. Now this is the other heminucleus, tilted, emulsification started from apex, and as I start eating up from one side, and it remains at the tip and it gets emulsified. Phaco energy, I have told, in this case is 85%. Flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. The machine being used is Faros from Oatley. The same cataract can be easily done by Oatley Easy or Oatley Cataracts 3. It's not necessary that you need a Faros for this hard cataract. And this is the last nuclear fragment. At this time I decrease the vacuum and flow rate little bit. Flow rate is 35, vacuum is 350, and I take care of the anterior chamber stability. I look at the posterior capsule movement. Everything is fine, so I just emulsify this last nuclear fragment, and it is done. So the nucleus is nicely emulsified, and now is the time to remove the cortex. Visco is again injected. A 23G Simcoe is being used to aspirate the cortex from the inferior aspect, say from 3 o'clock to 9 o'clock. The superior part can be removed by this instrument going through the side port, but in this case I am going to use bimanual irrigation aspiration for removal of the cortex, say from 8 o'clock to 1 o'clock. Here it is. Irrigation is from the right side port, aspiration from the left, and it is done. The cortex is removed. This is hydro polish. Yes. So polishing of the posterior capsule has been done, and now a single piece monofocal intraocular lens is being implanted in the capsular bag, keeping the antechamber formed by the irrigating probe. Yes, it is done. The lens has gone into the capsular bag. The lens is dialed by the irrigating probe. The capsular bag as well as the antechamber is irrigated. In this way, whatever visco or stere in the lumen of the cartridge has come out. This is a bit of moxifloxacin. And now the side ports are closed by hydration of corneal stroma on either side of these stab incisions. Side ports are closed. The main incision doesn't need any hydration. It has been made in that way. One more thing. See, the main wound is clear. There is no wound burn. And the ultrasonic energy has been applied in the continuous mode. Isn't it surprising? Yes. In Oatley machines, Faros or Catrix 3 or Catrix Easy, you can use ultrasonic energy in continuous mode intermittently, and you will never find wound burn unless you deliberately do it. The antechamber is nicely formed, integrity of the wounds are checked, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence. Friends, welcome to my workplace at
That was excellent innovation,
India.
sir, to deal with a very hard luminescent cataract. So now we have a second presentation of Dr. Pradeep Mohanta, sir, wherein he is going to talk about the use of pre-chopping and his transition from a direct phaco chop to pre-chopping. Okay.
Here. Divide with a pre-chopper and conquer. This is a totally unedited recording of phacoemulsification of this soft cataract. We can see there is a posterior subcapsular opacification, and the rest of the lens mass is very soft. It is very difficult to hold this nuclear mass with vacuum and chop, and it is time consuming to make trenches and divide this nucleus into 4 pieces. But if we use a pre-chopper, we can divide this nucleus into 4 pieces in a few seconds. Any equipment that saves our time and that helps us do things safely is worth adopting. In this case, I did the rexes going clockwise, and it is not difficult to do rexes going clockwise, and this has been a very satisfactory capsulorhexis of about 5.25 mm in diameter. And now hydrodissection. A 27 gauge cannula and BSS is being used to do hydrodissection. The nucleus is stabbed, some more hydro, and the nucleus rotates freely. Some visco is injected into the anterior chamber, and now I take the pre-chopper in my right hand and a sustainer in my left hand and do this fast division. and rotate the nucleus and divide this heminucleus into two pieces. Rotate it again and divide the other heminucleus into another two pieces. So in a few seconds we have divided the nucleus into four fragments, into four quadrants, which if we indeed tranches, it took much longer time, and it has been a very safe technique. And now we are going to engulf each nuclear piece by the phaco handpiece. Here it goes. Bevel down, some superficial cortical lens matter is removed, and this piece is emulsified using very low ultrasonic energy. Then the second piece, ultrasonic energy is set at 60%, but we are hardly using any ultrasonic energy in this case. And this is the last nuclear piece. See how quickly we have managed the nucleus. And now this is the epinucleus. Have to mobilize the epinucleus and remove it safely. So this has been a very satisfactory management of the nucleus and epinucleus using a pre-chopper. And this is a totally unedited recording. And now I'm going to remove the cortical lens matter with this 22 gauge Simcoe cannula. Yes, it is coming very easily. And now the subincisional cortex is removed and going through the sideboard. In this case, we have made only one sideboard. And now is the time to implant an intraocular lens. I'm going to use a B cartridge. So I'm going to enlarge the main wound a little bit, say by 0.2 mm. So the 2.8 millimeter incision becomes 3 millimeter. And now here is hydroimplantation of a single piece monofocal intraocular lens. The trailing haptic was distorted. Now it is coming into shape, and the lens is dialed to place the haptics about 90 degrees away from the main incision. And now moxifloxacin is injected into the anterior chamber. The sideboard is closed by hydrating corneal stroma, and then a final lavage of the anterior chamber is carried out. If we do a final lavage, the chance of TAS, that is toxic anterior segment syndrome, is reduced. And now integrity of the wounds are checked, few drops of moxie is applied over the cornea, and the case is concluded. Thank you very much for your attention. Hope this video will encourage you to use any instrument that saves your time and that helps you do the
safely. This pre-chopper is invented designed by Dr. Sohel from Nanded, Maharashtra. Congratulations to Dr. Sohel.
Sir, that was an excellent, very swift surgery. That was a very swift one.
Yeah. Congratulations, Sohel. It is a great innovation. I like it very much. And soft cataracts up to grade 3, I'm using it all the time.
the nuclear sclerosis.
Excellent videos.
Thank you. Thank you.
Excellent video, Dr. Pradeep and Dr. Deepak sir.
Thank you.
I have been a very great fan of Dr. Deepak sir. As a student, we used to, watch your videos. Just wanted to ask a question to Dr. Deepak and Dr. Pradeep sir. In this brown cataracts, in this brunescent cataracts, do we do specular microscopy on a regular basis before we proceed?
Yeah, we should do.
If you have access, you should do. We have access in our hospital, we do it. But otherwise, your clinical judgment would help, to choose. You can have a look at the cornea, and the patient is very aged. Then maybe you can suspect that the endothelium might not be very healthy. So maybe you take all the precautions. Dr. Pradeep, you can answer.
Yeah. We have access, so we do it. Otherwise, you can clinically judge the cornea, the clarity of cornea. You can look for cornea gut data. And if it is not there, you can go ahead with surgery.
Thank you. Thank you so much.
I think the age is an important criteria. Many other times, rarely you have older patients also having very good corneas. But if you don't have access, then please go to other parameters like age and appearance of the cornea in general. Look at cornea.
So one thing I have observed in your surgery is doing your brunescent cataract is the bevel was continuously posteriorly directed. That is the one reason I think your energy was not directed towards the endothelium and the cornea was clear. That is the one thing.
I use it horizontally like this mainly because the followability of the nucleus increases dramatically. So the nucleus occludability increases. So that is the main reason for us to use it like that. I don't think that plays a very significant role, but the plane where you hold the probe, that is critical. If your probe is at the level of the pupil or below it, then it's far away.
Do you shield BSS during surgery
not
surgery
really.
like this?
I used to use it before, but nowadays not really.
Yeah.
But I understand it does help this thing, but I don't use it now.
Yeah. Thank you.
Thank you, sir.
So I will be presenting a video of pre-chop in small incision cataract surgery.
This video is a valiant effort of a SICS surgeon to stand head-to-head with a phaco surgeon. While interchamber phaco-fragmentation is relatively easy, it definitely jeopardizes the endothelial integrity and defeats the very aim of obtaining pristine cornea day one post-operatively. Keener's technique uses a steel wire for producing phaco-fragmentation. While Guterres Carmona uses a tennis racket-like vectis against a solid supporting plate to crush the nucleus in the antechamber. Again, Dr. Boramani uses a AX chopper-like device to break the nucleus in the antechamber. And Dr. Peter Kansas very much popularized the bisector and trisector techniques of phacosection. In the back, phaco-fragmentation techniques are promising in being away from the endothelium. Akahoshi's technique is of course the gold standard among them. Unfortunately, it has got a very steep learning curve with a phenomenal amount of antechamber instability. MyLoop is the new kid on the block, but involves blind manipulation with known PCR-like complications. Though femtolaser is a very expensive viable option, it has its limitation in small pupil, very hard cataracts, and deep-seated eyes. We are now presenting a novel, sleek, and elegant pre-chopper without a cross-action to suit the nucleus of any density. So let's get started to witness the 1.9 millimeter MSICS for a moderate grade of cataract. 1.9 millimeter MAR is made on the sclera, and a scleral scratch incision is made as shown with a 0.5 millimeter posterior cuts. The scleral tunnel is now being designed into the clear cornea. side port incisions are also made as shown. A 2.2 millimeter keratome is used to enter the antechamber. After performing capsulorhexis and hydrodissection, superficial cortex is now being aspirated with the help of a Simcoe cannula. The nuclear rotation is now being ensured with the help of a dialer. The inner aspect of the tunnel is now being enlarged by 1 millimeter on either side. Antechamber maintainer is ensured, and an Akahoshi ball sustainer hooks the equator of the nucleus. The new pre-chopper, as described, divides the endonucleus into two halves. After rotation of the heminuclei, all these maneuvers are repeated to obtain multiple pie-shaped fragments of the nucleus. These are viscoelastic dependent maneuvers. The assistant is also injecting quite a good amount of viscoelastic through the antechamber maintainer. Once pie-shaped fragments are obtained, a microvectis is being now used to remove these fragments from the antechamber one by one. After cortical wash, finally, a foldable lens is now being implanted.
Amazing innovation, Sohel.
Actually, I wanted to show one more, but anyhow, the time is over. So
okay, time is over, is it?
Actually, it is 7:55 is the time. If you have still 4-5 minutes, we can go for another video. Otherwise, we can.
I think your innovation is a game changer. As I've been telling you, it is more for manual polycystic cataract surgeries, because until now, all the division techniques which we are using has all been in the antechamber, and corneal endothelium bears the brunt of it. Okay, all this learning, and if we can make more teaching videos for all the surgeons on how to use this pre-chopper and share practical tips, no, it will be a game changer for manual motion cataracts. Because in our country, that is a technique which is followed most. And the only reason why people go to phaco, because we can't have a controlled SIA, surgical induced astigmatism, wound becomes large. If you can able to bisect nucleus, it is great. And your technique is simply super, because we are using every manipulation in the bag itself. So that is the main advantage. That's what I feel. You should make more teaching videos, and because people are scared to place the chopper there at that end, that Chang chopper which you place at the end. That is the most important trick is that once you place it and then move it, it will be very easy. That's my personal opinion. Pradeep sir has demonstrated wonderfully well in utility in soft nucleus, but I really feel it is a game changer for manual motion cataract surgeries. That is my opinion. You really try to teach, make it much more simpler, and for the surgeons, it will be a very big hit, I'm telling you.
Sure, sir, sure.
Sohel, I would like to, if you can trisect the nucleus into 3 pieces, not 4 pieces, 3 pieces, then I think it will be smaller in size, if it is possible.
It was already pointed out by Dr. Meghur sir when I presented this video, same video in ISMICS Karnataka chapter, where he had given me a very nice suggestion, as you have suggested, to rather than going for 4 pie-shaped quadrant, you should come out with vertical kind of longitudinal
3 pieces.
So that they can be easily
for SICS.
Yes, so they can be easily negotiated through the tunnel. So I'm working on it, sir. So is the time over, ma'am? Is the time over? Yeah. So we are getting a warning also to conclude the session. So I'm very much
excellent
thankful.
Video, Dr. Sohel.
I'm very thankful to AIOS, the chairman Partha sir, and the entire AIOS team for giving me an opportunity and for the smooth running. I'm extremely sorry for the initial glitch we had in the presentation. I'm thankful to Dr. Meghur sir, Dr. Mohanta sir, Dr. Patwardhan, Saurabh, and Dr. Pampatwar for helping me and co-hosting and thank you, Dr. Aarti Agrawal madam also. Thank you very much, sir.
Thank you so much, sir.
Thank you, Dr. Aarti Agrawal.
Wonderful session, sir. Thank you very much.
Deepak, thanks. God bless you.